Welcome dear students, I am Dr. Pratyusha and in this video let us learn about labyrinthitis which occurs as a complication of otitis media. We are learning the complications of otitis media one after the other and in this video let us learn about labyrinthitis. Labyrinthitis is the inflammation of the labyrinth, that is the inner ear. And why does it occur? Either because of an extension of infection from the middle ear, that is otitis media, or from purulent meningitis. These are the two ways in which labyrinthitis can occur. Once again, what is labyrinthitis? It is inflammation of labyrinth. Let me show you a picture of the labyrinth to remind the inner ear anatomy. We have the bony labyrinth and running inside it exactly in the same way is the membranous labyrinth. I hope you can see all of that in this picture very clearly. This being the cochlea and the three semicircular canals. Now let us discuss about the etiology of labyrinthitis. Labyrinthitis could occur because of trauma. Trauma can again occur in two ways. One is a fracture of the skull. A skull fracture can lead to labyrinthitis. Second is an iatrogenic surgical trauma. A surgery of the mastoid or stapedectomy, mastoidectomy or stapedectomy surgeries can sometimes cause trauma to the labyrinth and cause labyrinthitis. This usually happens in the presence of a suppurative infection. After trauma, the next etiology is bacterial infection of the middle ear that spreads either through the round window or through the oval window and causes labyrinthitis. So, otitis media. Bacterial infection of middle ear called as otitis media. The third etiology is meningitis. Now, infection of the meninges can also cause labyrinthitis by two methods. One is retrograde spread of infection from the meninges into the membranous labyrinth. Retrograde spread of infection. And then extension of infection along the fluids, along the inner ear fluids. Now you all know that there is a connection between the subarachnoid space and the perilymphatic space of cochlea. How? Through the aqueduct of cochlea. So through the cochlear aqueduct, the subarachnoid space and the perilymphatic sac are in connection. Repeat. The subarachnoid space and the perilymphatic space are in communication with each other and through the fluid also infection can spread. So these are the three etiologies of labyrinthitis. First is by trauma, second is by otitis media and third is by meningitis. Now labyrinthitis is classified into three varieties. First among them is circumscribed labyrinthitis. Second is diffuse serous labyrinthitis and third is diffuse suppurative labyrinthitis. First, let us learn about circumscribed labyrinthitis. Now, circumscribed labyrinthitis is localized perilabyrinthitis following an inflammatory condition. So, circumscribed, as the word itself is suggesting, it is localized perilabyrinthitis. there is formation of a pathological fistula, mostly into the lateral semicircular canal. Now, in this type of labyrinthitis, there is thinning or erosion of bony capsule. Usually, the one that is involved is the horizontal semicircular canal. So, what are the two features? First, there is a pathological fistula. Pathological fistula involving the lateral semicircular canal. And next, there is thinning or erosion of bony canal. Erosion of the bony canal of horizontal semicircular canal. What are the causes of circumscribed labyrinthitis? Let us see. The etiology that is specific to circumscribed labyrinthitis. First and the most common cause is cholesteatoma. Cholesteatoma is the most common cause, followed by congenital syphilis, granulomatous diseases, any tumor of temporal bone, chronic otitis media, tumor of the middle ear, such as glomus tumor. Okay, all of these could be causes for circumscribed labyrinthitis. Okay, cholesteatoma being the most common cause. Other causes are congenital syphilis, granulomatous disease, tumors of the temporal bone and tumors of middle ear, plus any chronic otitis media. And there is one more cause, that is surgical or accidental trauma to labyrinth. Now, if we look at the pathology of labyrinthitis, in labyrinthitis, any part of the middle ear can be involved, but most commonly it is seen in the lateral semicircular canal. We have seen that the pathological fistula is also mostly involving the lateral semicircular canal. Now, the fistula erodes the bony labyrinth, but in a few cases, even the membranous labyrinth could be affected in the disease process. Let us look at the disease process in more detail. So, first, there is involvement of the lateral semicircular canal. Bony labyrinth is eroded and there is fistula formation. In some cases, even the membranous labyrinth could be affected. Now, this disease process starts as a circumscribed lesion, but in the late stages, it becomes diffuse. And there could be breakdown of the middle ear mucosa, and this is followed by resorption of a portion of the labyrinthine capsule. Bone resorption begins along the vascular channels. Ultimately, bone resorption of the entire labyrinth occurs. It begins at the vascular channels. So, in the late stages, the disease process becomes diffuse from circumscribed. Let us look at the clinical features now. When the membranous labyrinth is exposed, after the bone has been eroded, the membranous labyrinth is now exposed and this becomes sensitive to pressure changes. So, it causes recurrent attacks of dizziness, episodes of vertigo and nausea. And these are aggravated by head movements. Okay. So, first, the beginning point is exposure of membranous labyrinth. This will lead to recurrent attacks. Now the membranous labyrinth has become sensitive to the pressure changes. Until now it was shielded, well protected inside the bony labyrinth. After it is exposed due to the erosion of bone, it leads to recurrent attacks of vertigo and nausea. These are aggravated by head movements. And they last for about a week. Patient complains of transient vertigo when we apply pressure, we increase the pressure in the ear. How can we do that? By two maneuvers. One is by putting pressure on the tragus, or we can increase pressure by using Siegel's speculum. So, this is what we call as performing a fistula test. In fistula test, pressure in the external ear is increased and we try to bring about nystagmus and vertigo. How is the pressure in the external auditory canal increased? By pressing the tragus. When the tragus is intermittently pressed inwards, the air pressure in the ear canal increases and this is transmitted into the middle ear and this is in turn transmitted into the labyrinth and the labyrinth is stimulated. When the labyrinth is stimulated, patient complains of vertigo. And what you will observe? Nystagmus. Nystagmus is seen. Now, nystagmus has a quick component and a slow component. The quick component is towards the affected ear. Now, this can also be done by a Siegel's speculum. With a Siegel's speculum, when we increase the pressure, same thing happens. The pressure changes are transmitted into the inner ear and patient complains of vertigo and nystagmus is observed. Why? Because the labyrinth is stimulated. And same, the quick component of nystagmus is towards the affected ear. Now, when the quick component is towards the affected ear, we call it ampulopetal displacement of cupula. When the quick component is towards the affected ear, it is called as ampulopetal. Petal means towards. Ampulopetal displacement of what? Of cupula. Now, Siegel's speculum can be used for two purposes, to increase the pressure and to decrease the pressure. When positive pressure is applied, the same thing happens as in pressing of tragus. But when negative pressure is created in the external auditory canal, let us see what happens. This will also induce vertigo and nystagmus, but now the quick component of nystagmus is directed to the opposite side, that is to the healthy side. And what do we call this? ampulofugal displacement of cupula, away, opposite side, ampulofugal displacement. When negative pressure is applied, labyrinth is stimulated and patient complains of vertigo, and you observe nystagmus. And here the quick component is away from the affected ear. What is this called as? Ampulofugal displacement of cupula. This is about the fistula test, which is done to diagnose labyrinthitis. What about the hearing of the patient? Hearing is usually within normal limits, or sometimes there could be just mild conductive type of hearing loss. Now let us move on to the investigations. The investigations are pretty simple. We just do two things. One is a CT scan of the temporal bone, followed by an audiogram. Now let us look into the treatment of circumscribed labyrinthitis. First, medical treatment. Medical management is by antibiotics. They play a role in the acute stage, which is caused by infection. Antibiotics. And also labyrinthine sedatives are used. Why are labyrinthine sedatives used? For vertigo and dizziness that the patient is experiencing because of stimulation of membranous labyrinth. And now let us look at the surgical management. Mastoidectomy and closure of fistula. If fistula is present, it has to be closed. This is done when a labyrinthitis has occurred because of otitis media. If it has occurred because of meningitis, only systemic antibiotic therapy has to be given. Before and after performing the surgery, systemic antibiotics have to be given to prevent further infection. So what are the surgeries that we do? One is mastoidectomy, and the second is closure of fistula. Let me quickly revise about circumscribed labyrinthitis. It is a localized perilabyrinthitis where you see a pathological fistula mostly affecting the lateral semicircular canal. Erosion of the bony canal is also seen, and coming to the etiology, cholesteatoma is the most common cause, and if you look at the pathophysiology, the lateral semicircular canal is most commonly affected and the bony labyrinth is first eroded and a fistula formation occurs. In some cases, even the membranous labyrinth is eroded, and in the late stages, this circumscribed labyrinthitis becomes diffuse labyrinthitis. Coming to the clinical features, because of the membranous labyrinth exposure, the patient experiences recurrent episodes of vertigo and nausea. And if you do a fistula test, you will observe that when positive pressure is applied by pressing the tragus or by using a Siegel's speculum, the quick component of nystagmus is towards the affected ear. And when negative pressure is applied, the quick component of nystagmus is away from the affected ear. This is ampulofugal. And when it is towards, it is ampulopetal. Coming to the investigations, a CT of temporal bone and an audiogram are performed. And the treatment part, antibiotics plus labyrinthine sedatives are used, followed by surgical treatment, which involves mastoidectomy and closure of fistula. So this is about circumscribed labyrinthitis. Now let us move on to the second type of labyrinthitis, that is diffuse serous labyrinthitis. The diffuse intralabyrinthine inflammation without pus formation is diffuse serous labyrinthitis. If pus formation occurs, it becomes diffuse suppurative labyrinthitis. Now, this is a reversible condition if treated early. Let me write that down for you. What is diffuse serous labyrinthitis? It is diffuse intralabyrinthine inflammation. Intralabyrinthine inflammation. And what is the second important point? There is no pus formation. Because we are talking about serous type. What is the etiology for diffuse serous labyrinthitis? Most often it arises from the pre-existing perilabyrinthine circumscribed labyrinthitis. We have discussed in circumscribed labyrinthitis that in late stages it becomes diffuse. So this is also associated with a chronic suppurative otitis media or cholesteatoma. Most commonly, it arises from a pre-existing circumscribed labyrinthitis. Sometimes in acute infection of the middle ear cleft, the inflammation spreads through the annular ligament of the oval window or the round window. So, in acute suppurative otitis media also, the inflammation can spread via the annular ligament of oval or round windows. When mastoidectomy surgery is done in the presence of circumscribed labyrinthitis without giving proper antibiotic cover, that can also lead to diffuse labyrinthitis. Mastoidectomy surgery in the presence of labyrinthitis, circumscribed labyrinthitis. This can even follow surgeries of the inner ear such as stapedectomy or any fenestration operation. And finally, trauma also can cause. Trauma, be it surgical trauma or any accidental trauma. Now let us look at the pathophysiology of diffuse serous labyrinthitis. The main point is that it is non-purulent type of inflammation and there is cellular infiltration of serous or serofibrinous exudate. Let me write that for you. Most important point, it is non-purulent. Non-purulent inflammation. Plus, there is cellular infiltration of serous or serofibrinous exudate. Diffuse labyrinthitis occurs as a result of chemical changes. Now, these chemical changes are taking place in the perilymphatic space. They are caused by some toxic or suppurative process, and this later impinges on the membranous barrier of the labyrinth, such as at the round window, and it causes a bony fistula. So, first, chemical changes are occurring in the perilymphatic space. and these are later on impinging on membranous barriers. What are the membranous barriers you can think of? The round window or secondary tympanic membrane. And this will later lead to the causation of a bony fistula. Is the pathology of diffuse serous labyrinthitis clear? There is non-purulent inflammation and chemical toxic changes are occurring in the perilymphatic space, and they are spreading onto membranous and later causing bony erosion. Now let us look at the clinical features. Here also the patient complains of vertigo and nausea in mild cases. In severe cases, what happens is vertigo and nausea in mild cases. In severe cases, the vertigo is even more worse with marked nausea, vomiting and spontaneous nystagmus. Now this vertigo could be either spontaneous or rotational type. Severe vertigo, nausea and vomiting plus spontaneous nystagmus are observed in severe cases. Because the inflammation is diffuse, here the cochlea is also affected with some degree of sensorineural type of hearing loss. Now in circumscribed labyrinthitis, only one part was affected and it was usually the membranous labyrinth, not causing much hearing loss. There was no hearing loss, I could say, or if present also it was very mild conductive type. But here, because it is diffuse and even the cochlea is getting involved, there is sensorineural type of hearing loss. Why? Due to involvement of cochlea. This is one important difference. And here also nystagmus is observed and the quick component is towards the affected ear. Quick component is towards the affected ear. Fistula sign is positive when it is secondary to circumscribed labyrinthitis. Now we have learned that in circumscribed labyrinthitis, fistula formation occurs, and if that circumscribed labyrinthitis progresses to diffuse serous variety, here also fistula sign will be positive. And this serous labyrinthitis, if it is not controlled here, this can progress into suppurative labyrinthitis, and that time there could be a total loss of vestibular and cochlear function. Now these three types could be present as three different types: circumscribed, diffuse serous and diffuse suppurative, or you can also observe that they could be studied as three stages. Circumscribed is progressing into diffuse serous, and diffuse serous, if not controlled, could progress to diffuse suppurative type. Okay, I hope the clinical features of this type are also clear. Fistula test is positive if it is secondary to circumscribed variety. And for this treatment, we have to immediately treat the condition so that it does not progress to suppurative labyrinthitis, because suppurative labyrinthitis can cause complete irreversible destruction of labyrinth and also the cochlea, and later on that can spread to meninges and cause meningitis also. So how do we treat the condition? Medical treatment, the patient is kept in a supine position and the head is immobilized. The affected ear is placed above. Suppose this is the affected ear, and when the patient is sleeping, this ear is kept above. That is the position in which the patient has to rest. Antibiotic therapy, of course, we have to give. First, the patient is rested in supine position with affected ear above. Next, antibiotic treatment is of utmost importance, although this is a non-purulent condition, so that there is control in the spread of infection and this does not progress to diffuse suppurative variety. And now the major complaints of the patient are vertigo and nausea, vomiting, dizziness. So to control them, to provide symptomatic relief, we use labyrinthine sedatives. Labyrinthine sedatives. Coming to surgical treatment, we have to do a myringotomy if the labyrinthitis has followed acute otitis media with vertigo and there is bulging of tympanic membrane. Doing a myringotomy, we can draw all the pus and there will be relative relief to the patient. And whatever pus is obtained, it is sent for culture and sensitivity to culture and sensitivity to guide antibiotic therapy. Myringotomy is done. If it is secondary to acute otitis media. If at all there is acute mastoiditis, then cortical mastoidectomy has to be done. If at all there is cholesteatoma, then modified radical mastoidectomy has to be done and the source of infection has to be treated. But always remember, medical treatment should precede surgical intervention. What is the surgical intervention? Mastoidectomy. I hope diffuse serous labyrinthitis is clear to all of you. Now let us move on to the last type of labyrinthitis, and that is diffuse suppurative labyrinthitis. This is diffuse pyogenic infection of the labyrinth. Plus, an important feature of this is there is permanent loss of vestibular and cochlear functions. Okay, and this could be purulent, peri and endolymphatic condition. Both the perilymph plus the endolymph are affected. But the most important point is there is permanent loss of vestibular and cochlear functions. So there is diffuse pyogenic purulent. Serous was non-purulent. Suppurative is purulent. Pyogenic infection of labyrinth. There is permanent loss of vestibular and cochlear function. Both the perilymph and endolymph are affected. Coming to the etiology, this usually follows diffuse serous labyrinthitis. We have learned this point in diffuse serous labyrinthitis also, that if it is not contained or controlled there, it can progress to a purulent condition, diffuse suppurative labyrinthitis. The pyogenic organisms enter through the fistula that is present. So, the most common etiology is following a diffuse serous labyrinthitis, which was in turn following circumscribed labyrinthitis. Okay. Next, it can also occur because of chronic suppurative otitis media and cholesteatoma. And it can also occur because of a subdural abscess or meningitis. These are the various methods in which, various causes by which diffuse suppurative labyrinthitis can occur. Now let us look at the pathophysiology of this disease. In the acute stage, there will be infiltration of labyrinth with neutrophils. Plus, there is destruction of soft tissue structures. There is infiltration with neutrophils plus destruction of soft tissue. The bony labyrinth can also get necrosed. The osseous labyrinth is also destroyed. Initially soft tissue followed by bony labyrinth. After this entire destructive process, granulation tissue may form. This granulation tissue forms like a wall around the necrotic bone, and it forms one or more sequestra. The problem in this entire thing is sometimes paralysis of facial nerve could occur, and the infection can extend into the intracranial structures also, depending upon the virulence of the organism. All this occurs in the acute phase. After the bony labyrinth is necrosed, granulation tissue is formed, which acts like a wall around the necrosed bone. Later on, facial nerve paralysis could occur and the infection can spread into intracranial structures. All this in the acute stage. The chronic stage follows 2 to 3 weeks after the onset of acute suppurative labyrinthitis. The granulation tissue that has been formed will gradually change into fibrous tissue, and that fibrous tissue will later undergo calcification and new bone is formed. In half of the cases, the new bone that is formed will partially or completely fill the labyrinthine spaces in a span of 6 months to 1 year. So, the granulation tissue in the chronic stage will get converted to fibrous tissue, and this is followed by calcification and new bone formation. This new bone fills the membranous spaces. In about half the patients. Okay. So, the routes of infection, there are 3 routes of infection. One is the tympanogenic route, that is otitis media, mastoiditis, petrositis, temporal bone fracture, penetrating injury, middle ear surgeries and tumors. All of them from the middle ear part it is occurring. Second is a meningogenic route via the meninges it is occurring. Third is hematogenous route from distant or any systemic infection in the adjacent areas or anywhere else in the body. Either it could be close by structures such as meninges, brain abscess or encephalitis, or anywhere from distant infection also via the blood. The infection the infective organisms are brought into the labyrinth. So these are the three routes of infections. And there are certain predisposing factors for this to occur, and some of them are a Mondini deformity or an enlarged vestibular aqueduct or the presence of a fistula or the cochlear aqueduct patency or the internal auditory canal is weak or dehiscent, or when a stapes surgery has occurred. All these conditions will predispose the patient for the occurrence of diffuse suppurative labyrinthitis. Now let us look at the clinical features. In the acute stage, what we see is there is rapid onset of tinnitus, ringing sensation in the ear. So first there is rapid onset tinnitus, whirling vertigo, next we see diaphoresis. These symptoms remain very severe and they may not even respond to treatment for about 8 to 12 hours. They are very severe. Slowly dizziness will improve in the next few days, but movement of the head will again cause severe vertigo and nausea. In 2 to 3 weeks, CNS compensation will occur. So the acute stage lasts for about 1 to 2 weeks. When CNS compensation begins to occur after 2 to 3 weeks, let us see what happens. First is there is brisk jerky nystagmus. Horizontal nystagmus has the quick component on the affected side for first day, but this is irritative, so this can change towards the opposite side also, which is paralytic. So the first thing that we observe is brisk and jerky nystagmus. Then the vestibular symptoms peak during the first few days and then they gradually subside after the first week. The patient lies quietly on the affected side but cannot stand or sit because the head movements will aggravate vertigo. Even slight head movements will produce vomiting also. And there will be complete hearing loss. And then, let me write this. The vestibular symptoms subside after first week, but head movement causes vertigo and vomiting. Then there is complete hearing loss. And when the pointing test is done, there is past pointing and fall also occur towards the deceased side. Now please remember that a unilateral labyrinthitis produces more severe vestibular symptoms than bilateral meningogenic labyrinthitis. Okay, remember that a unilateral labyrinthitis causes more severe symptoms than bilateral meningogenic labyrinthitis. And here the fistula test is negative. Why is the fistula sign negative? Because of a dead labyrinth. Even though a fistula is present, the sign is negative because the labyrinth is no longer able to respond to the fistula also. So, another very important point is the fistula sign is negative. In circumscribed labyrinthitis and diffuse serous labyrinthitis, the fistular sign is positive. Here it is negative. Now then let us move on to the second phase, that is chronic phase, or it's also called as the latent stage. Chronic or latent, also called as the fibrous stage. This lasts for 1 to 6 weeks. In the chronic stage, there is only mild vestibular upset and positional vertigo is seen. The vestibular symptoms are mild. There is positional vertigo plus absence of both cochlear and vestibular function. Now the first point I told you about diffuse suppurative labyrinthitis is there is permanent loss of both vestibular and cochlear functions. So there is absence of cochlear as well as vestibular functions. Now when both sides are affected, bilateral lesions, it will cause difficulty in walking, especially in dark areas and on soft surfaces. Bilateral lesion makes the life of the patient very difficult. Then comes the third stage, which is a healed stage. This healed stage is also called as compensated state or ossification stage. Compensated or ossification stage. Another name for this is labyrinthitis ossificans. Here, new bone formation occurs. This will take several months and many years are required for the development of complete labyrinthitis ossificans. This is the last stage where bone is formed. This is about the clinical features of diffuse suppurative labyrinthitis. In acute stage, the symptoms are very severe, and then comes the chronic stage and finally the healed stage. Let us now look at the investigations. For this, caloric test is done and it shows canal paresis. Then audiogram when done. Because of the complete destruction of cochlea, there is profound sensorineural type of hearing loss. We can do a contrast enhanced CT or an MRI to look at the extent of destruction. And even a CSF examination is done. Why a CSF examination done? To rule out meningitis. These are the investigations performed. Coming to the treatment part, medical treatment consists of absolute bed rest, labyrinthine sedatives to relieve the patient of the vestibular symptoms, plus antibiotics. complete bed rest, labyrinthine sedatives, plus antibiotics. Coming to the surgical treatment, mastoidectomy with labyrinthectomy is necessary when there are threatening intracranial complications. Now please understand that the labyrinth is anyhow damaged and dead. We are doing the surgery to prevent further complications. When this intralabyrinthine infection is acting as a source of intracranial complications, then drainage of the labyrinth is performed. Mastoidectomy plus labyrinthectomy. Why is this done? To prevent intracranial complications. So this is about diffuse suppurative labyrinthitis. And with this we complete the entire topic of labyrinthitis also. Let us quickly recap everything from the beginning. So labyrinthitis is inflammation of the labyrinth. The three main etiologies are trauma, otitis media and meningitis. And there are three varieties. First is the circumscribed labyrinthitis, where there is localized perilabyrinthitis and a pathological fistula is seen. Mostly the lateral semicircular canal is affected and the most common cause is cholesteatoma. In the pathology, we find that the lateral semicircular canal is affected, initially bony labyrinth, and in some cases membranous labyrinth could also be affected. And in late stages, this circumscribed lesion becomes diffuse. Coming to the clinical features, because of the exposure of membranous labyrinth to the environment, there occurs vertigo and nausea, which are aggravated by head movements. And on doing the fistula test, we find vertigo and nystagmus. Coming to the investigations and treatment, you already know them. CT of temporal bone, audiogram, and treatment is by antibiotics and labyrinthine sedatives. The next one is diffuse serous labyrinthitis. In this, there is diffuse labyrinthine inflammation, but the important point is there is no pus formation. Etiology, it most commonly follows a circumscribed labyrinthitis. Sometimes it can also occur from acute suppurative otitis media via the annular ligaments of either the oval window or the round window. And when mastoidectomy surgery is done in the presence of circumscribed labyrinthitis also, this can occur. Looking at the pathological features, most importantly, it is a non-purulent type of inflammation, and you will see chemical changes in the perilymphatic space which impinge on the membranous barriers, followed by causing bony fistula. And in the clinical features here also we have vertigo and nausea and sensorineural hearing loss because of involvement of cochlea. And fistula test is positive here also. So fistula test is positive in circumscribed variety and diffuse serous variety. It is negative in diffuse suppurative variety because of dead labyrinth. Treatment, again, patient is rested, antibiotic therapy plus labyrinthine sedatives. Now the treatment is more or less common for all the three stages. Coming to diffuse suppurative labyrinthitis, there is diffuse pyogenic infection. And the most important feature, there is permanent loss of vestibular and cochlear functions. The perilymph and endolymph are affected, and etiology is this usually follows diffuse serous labyrinthitis. It could be after CSOM or cholesteatoma. It could be from a subdural abscess or from meningitis also. In pathophysiology, we see infiltration with neutrophils, destruction of soft tissue followed by destruction of bony labyrinth. And then a granulation tissue is formed around the bony necrosed parts. And facial nerve paralysis could also occur. In the chronic stages later on, what happens is this granulation tissue is replaced by fibrous tissue which is later calcified and a new bone formation occurs. So the clinical features are, in acute stage, the symptoms are very, very severe, and there is tinnitus, vertigo and diaphoresis with brisk, jerky nystagmus. The symptoms usually subside after 1 week, but head movement will still cause severe vomiting and vertigo in the patient. And please remember this peculiar point that a unilateral labyrinthitis causes more vestibular symptoms than bilateral labyrinthitis. Next, a fistula sign is negative, as we have already discussed. Why? Because of dead labyrinth. Then in the chronic stage, we find milder symptoms, but there is complete absence of cochlear and vestibular functions because of the permanent and irreversible damage that has occurred to them. Bilateral lesion will cause difficulty in walking. And last stage is the healed stage, also called as labyrinthitis ossificans, where new bone is formed. Coming to investigations, we do the caloric test, audiogram, CCT and CSF examination to rule out meningitis. Treatment again consists of medical and surgical treatment. In medical treatment, we give complete bed rest, labyrinthine sedatives and antibiotics. Surgical management consists of doing mastoidectomy and labyrinthectomy, and both are done to prevent intracranial complications. But at this stage, nothing can be done for the ear because it's permanently and irreversibly damaged. So this is about labyrinthitis, which we have studied as a complication of otitis media. I hope you have understood the topic in detail and properly. Thank you very much and have a nice day.